Hi, gents. Love the show. The work you do to educate the masses on hormonal health and well-being is invaluable. Well, thank you.
Yes.
Thank you. This might be the most complex case question that's ever been emailed to the show. Well, we'll be the judge of that, right?
Oh, I think it's a long one.
Well, I make them long. I'm sorry. I'll try.
No.
I'll try to be brief. Unfortunately, I have no recent blood work to attach. I'm in Canada, so we do things a little differently up here, just as a warning. But I think you might be aware of this. My story. I'm 42, about 6 weeks shy of my 43rd birthday. I was born with spina bifida, with complete paralysis from the waist down, and had a kidney transplant at the age of 25. An undescended testicle was removed during the transplant procedure. Despite this, I've tried to live as close to a normal life as I can for a guy my age, job, social life, etc. I've suffered depression and anxiety most of my life. About 6 years ago, I began hearing about testosterone replacement as a means for lifting depression, so I talked to my doc and got on a 1 ml dose, 200 milligrams, of testananthate every other week. I quit cold turkey because of the mood swings. Tried Antigel several months later. Disaster. Well, already, just picking up on our last question, no AI, this is a perfect reason why possibly this gentleman didn't have success with replacement therapy, but I digress, right? Sorry. Fell into another depression and decided I'd had enough in April 2018 and got back on 0.3 mLs, 60 milligrams of testosterone enanthate twice a week, subcutaneously. It worked miracles, and I've lost probably 25 or 30 pounds since. However, my prescribing doc is a family doc with an interest, he says in quotes, in TRT, failed to inform me that my estrogen might skyrocket. E2 was 94 picograms per milliliter at its highest this summer. Yeah, I know, 15 to 25. Trust me, I know. I've always been overweight, which doesn't help that process. Excuse me. I was put on 0.25 milligrams of anastrozole every few days. I hated the side effects, hot flashes, tachycardia, etc. So I'm essentially doing the same dose on a weekly basis. However, it seems to be that when I take it and have any sort of renal function blood work done in the day or two afterward, my creatinine is elevated. Not necessarily clinically, but typically about 10 to 15% above my own baseline. Okay. I notice it has a bit of a diuretic effect after I take it, to a degree where I'm sometimes thinking, where's all this water coming from? And that after this effect goes away, I don't produce as much urine as I think I should. Is this a known effect of anastrozole? Well, not necessarily of anastrozole, but of what anastrozole can do for you, which is to regulate estrogen, which in of itself can make you hold water. Meaning, again, excess estrogen. Is it just the body's way of releasing the water weight that I might have gained from the elevated E2, he asked. Yes, beat you to it. Is this something you've encountered in your vast experience and evaluation in creatinine, after taking the AI, or is it simply just that I'm a little, or more than a little, dehydrated on the day that I do my bloods, and it's all coincidental to that? Since this is a long one, I'm going to interject again here. Definitely, I already explained about the water weight gain, and definitely, yeah, if then you shed the water, you'll be drier, you'll be dry, we call it, and then the concentrations will be higher. But in general, and without seeing this patient and having a body comp, in general, I mean, where do we get creatinine from? Breakdown of muscle tissue. So people on TRT tend to, because it leverages, testosterone does, the effects of training or just day-to-day activities. You know, if it's even just pushing yourself around, I mean, that's activity, and the muscle you would leverage with that would be better leveraged with testosterone, right? So you have more muscle mass, you have higher creatinine levels. Creatinine, I don't know if we talked about this before, but creatinine is not the best, it's not the ideal way to measure kidney function right off the bat. No, because serum creatinine can be elevated from reasons I just said. You got somebody who's a well-muscled individual, training hard regularly and breaking down that tissue, you know, in between building it back up again, and they'll have elevated creatinine levels.
What would you say is an acceptable level for a bodybuilder? Because usually it's I know a little bit about this. Find out 0.9 to 1.2 is what they consider normal for a normal person.
And what's normal? Anatomic man is what, 5'9", 154 pounds or something like that?
That's their numbers.
Right.
Yeah.
So, and I don't know if those numbers are based upon anatomic man. I think they're more based on, and I'd like to know, because if you look at a laboratory assay, for example, an LDL number, that's certainly what I see in my practice as normal. Someone, in my opinion, made that one up. But the creatinine numbers there, are those intended to be ideal? How could they be? Because to your question, it varies so much. If you see a 1.5 level creatinine in a 90-year-old woman who's 90 pounds, you probably have a problem.
Right.
If you see a 1.5 in a 260-pound, 30-year-old, bodybuilder, you go, wonder why it's not higher. Because again, it's a product of muscle tissue breakdown that goes through the body unchanged, goes through the kidneys unchanged. So we assume, and what happens when we assume, that the kidney is not doing its job properly to filter, but it's not changing it. The creatinine out of the blood into the urine fast enough. Well, when this comes up, and it does every once in a while, because a primary care physician or somebody who doesn't have experience with TRT will look at this bodybuilder and go, "Oh my God, what you're doing is killing your kidneys. You better get off that stuff right now."
Yeah.
You get a 24-hour urine collection, and you see serum levels are 1.5, but the measured creatinine in the urine is in the thousands. It's off the chart. Okay. And I'm not giving you measurements again, but trust me that you can see the difference. This is what it's supposed to be versus what it's supposed to be here, and you're seeing the kidney's working great. There's tons of creatinine. It's just that the individual is making lots of creatinine. The kidney's working overtime to get rid of it. It's working great, in other words, very effectively. So it doesn't necessarily mean there's a kidney problem. As you could argue it's worth investigating depending upon other facts of the case.
So if you did a urine analysis, that would be actually a good idea for him, possibly.
Yeah.
Yeah.
But to his point about the serum creatinine being high or low, yes, if your blood is diluted, if you will, the creatinine level is diluted because you're holding some water, then it'll be lower, then it will change. And I think his case, he makes a good one. I would totally agree. That's very possible, depending upon when you're doing this testing, that the AI that he's taking is probably not enough, or it's not timed properly, one of the two, or both. And so when he brings his estrogens back down, he loses some of that water, and his creatinine levels therefore rise because it's not as diluted. In effect, they haven't really changed, but it just looks like they have. So I can buy that. It's not necessarily, doesn't prove that's what's happening. But yeah, it makes sense. So is that all he asked? It was about creatinine, right? So then I've often wanted to experiment and increase the AI dose because I still get some of the mental symptoms of high E2, but I don't want to risk damaging the gift of my transplant. Okay, so this is very important. Yeah, we need to rule out that it's not a problem with your kidneys. Your kidneys are working fine. You're not risking them, so you don't have to think that way. In other words, but it'd be worth doing the testing to find out one way or the other, right? Theoretically, understanding you can't actually dispense medical advice, would bumping it up to 0.25 twice a week be safe? Again, in theory, absolutely, and arguably, again, I would want to go back to something you said about getting some side effects from assuming it was from the anastrozole itself. You mentioned though that hot flashes, tachycardia, those are typically associated with decreased levels, deficiency, if you will, of estrogen. So the assumption would be that, yeah, you oversuppress the estrogen. But with a dose of anastrozole that small, it's not as likely that that's what's happening. And particularly since you mentioned that your E2, if it was sensitive, then I would assume it's precise enough to be accurate, of 94 picograms per milliliter, then that doesn't make sense at all, because that's excessive. But it's very important we differentiate between estradiol and estradiol sensitive. The estradiol, which is typically for a female, right, originally, is not precise enough to be accurate. The other day I saw something just nuts. I used to quote the one I saw originally. I saw the same, on the same lab draw, the assay for estradiol and the assay for estradiol sensitive. The sensitive was 16 picograms per milliliter. The regular was 94. The other day I saw one come back, it was like 4.6 sensitive and 207 regular. It's so imprecise to be that inaccurate. So guys that are using just estradiol, you are wasting your time. I say guys, yeah, not gals, because it doesn't matter that it's that precise. But again, we need to flesh this out to see if it's the anastrozole, in other words. And some people do have, it's very rare, but I believe some people may have a reaction to the actual drug itself, but very rare. So we might try a SERM or maybe even a suicide inhibitor like exemestane instead of anastrozole, and get different results. But I can't say much more because again, if that were a legitimate level, 94 picograms per milliliter, then you're not going to have hot flashes and palpitations from that. Something else was doing it. It wasn't from the excess estrogen, because that would imply, again, you get those symptoms from oversuppressed estrogen. Anyway, he adds, additionally, given the fact that I am paralyzed and unlikely to have kids, but do enjoy a fairly decent sex drive, would ACG be of any benefit if it was added to my protocol? I've heard, if nothing else, it can be good for mood in some cases. Every single doc I've dealt with, again, I'm Canadian, take that for what it's worth. He's backing on your country, man. Dave will stand up later to answer this question in other ways regarding the Canadians. Has told me they're not comfortable adding in ACG because it's stacking. If ACG would be a benefit, what would be the counter argument to the I don't want to prescribe it, it's stacking argument? Well, I don't know what stacking means in what they're saying, but stacking normally implies you're using more than one thing to do the same. In other words, in bodybuilding circles, it's 3 different anabolic steroids. We call that stacking the steroids, right? In this case, I guess the argument that the physician's making is that the endogenous production of testosterone is being stacked on top of the exogenous provision, and that's stacking. Depending upon your age and what effect you got, presumably using ACG first, you could flesh out how much is contributing to either, but who cares? The idea is to get to the cheese, right? You want to get to a certain testosterone level, so who cares if it's from this way or that way?
Right.
I don't understand the argument, so that would be what I would counter to the physician as a suggestion, like fleshing this out, or just find another physician, because I don't know what the problem is. In terms of the sex drive, it sometimes helps. We don't know why, but rarely, again, someone gets on TRT, doesn't get the libido enhancement that we expect, going from a fairly low testosterone to then a replacement dose, which is we dialed it in and it's spot on. They add the ACG and boom, my libido's back.
Wow.
We don't know why, because the estradiol doesn't seem to change, right? Why is that happening? We don't know yet. Let's see. He says, lastly, that's a hell of a lot of questions. I know. Thank you for at least taking the time to look it over, or even if it doesn't get into a video. So much for being brief. Cheers, Dr. Ren and Dave. Thank you again for your service. You cut that one out. Sorry. Cheers, Dr. Ren and Dave, and thank you again for your service to the community of folks who are just trying to feel their best. Ian. Did we hit everything there? We talked about the liver, the creatinine. It brings up that whole thing about the AI, and actually, there is something in there to take home about AIs possibly being bad for you, but it's not because of the oversuppression of estrogen necessarily, although that's one way, that anything, AI or otherwise, a SERM, if you're blocking the reception of or the production of enough estrogen that you're so-called deficient in it, you can have side effects. But again, rarely, but it seems to me that there are some people who, when we use, for example, anastrozole, the most popular, arguably, AI out there, they have issues, but we change to a SERM, for example, like tamoxifen, they go, oh, now I'm good. Okay, either way, you're effectively lowering the body's ability to respond to estrogen, right? Either by limiting the estrogen, or in this case, with the SERM blocking the receptor.
Right.
It should be the same, but that in that regard, you figure, okay, it must be the drug itself that's causing the issue. But that's very rare.
Yeah. Cool. Well, since he was so nice and it was long, we'll make sure that we put this one very soon on the channel. Thank you.